Good morning, students. Welcome to today's lecture. Previous week we had started this new topic on cysts of jaws and soft tissues. In today's topic we are going to discuss in detail about radicular cyst. Previous week we had discussed about the classification of cysts and we had also discussed in detail about mucocele. So the learning outcomes for today's topic will include description of the clinico-pathological aspects of radicular cyst in detail. At the end of this topic, we will also be able to identify and illustrate the histopathological features of radicular cyst. We will also be able to recognize the significance of a histopathological report of cystic lesion and suggest treatment options. Before we start with the topic in detail, let us revise the classification. It is important to understand the classification of cysts of each cyst to understand the cyst thoroughly. So to revise, cysts can be broadly classified into non-epithelial cysts or epithelial cysts. The non-epithelial cysts are also referred to as pseudocysts, while the epithelial cysts are also known as true cysts. Epithelial cysts can be further classified on the basis of the origin of the epithelial lining into odontogenic cysts and non-odontogenic cysts. Odontogenic cysts can be further classified into developmental cysts and inflammatory cysts on the basis of its pathogenesis. So the focus of today's topic, that is radicular cyst, is classified as inflammatory cyst. So to understand the radicular cyst, we need to know where in the classification this cyst stands. So, to summarize, radicular cyst is an inflammatory cyst of odontogenic origin. Before we discuss the topic in detail, let us know the terminology of this cyst. The term radicular means in relation to the root. Cyst, on the other hand, is defined as a pathological cavity which may or may not be lined by epithelium and which consists fluid, semi-fluid or gaseous content but not the accumulation of pus. So, a radicular cyst is a cyst which is present in relation to the root of a tooth. Why is a radicular cyst considered a odontogenic cyst? To understand this, we need to look back into the topic of oral biology where we discussed the topic odontogenesis. As we all know, odontogenesis is the formation of tooth from the dental lamina which gives rise to complex structures like the enamel organ. The enamel organ gives rise to specialized cells which results in the development of crown. At the completion of crown, a two-layered structure called the Hertwig's epithelial root sheath is formed from the outer and inner enamel epithelium, which extends downwards or apically to give rise to the root. So this Hertwig's epithelial root sheath would give rise to the development of the root. Following the completion of root, this Hertwig's epithelial root sheath gives rise to certain resting cells, also referred to as epithelial cell rests of Malassez. These cell rests reside in the periodontal ligament space and are quiescent throughout the life. It is these epithelial cells rests of Malassez which has the potential for development into a cyst, and these are the cells which are related to the radicular cyst. Inflammatory reaction is a key event in the pathogenesis of radicular cyst. Hence, radicular cyst arises as a result of inflammation. That is why radicular cyst is an inflammatory cyst of odontogenic origin. So, before we go further into this topic, let us know some key facts. Radicular cyst is the most common odontogenic cyst. We would come across a number of such pathologies during our clinical practice. Hence, a thorough knowledge of this pathology is important. Radicular cyst is also referred to by certain other synonyms such as periapical cyst and less commonly the apical periodontal cyst. Radicular cyst commonly occurs as a sequelae of odontogenic infection, that is, dental caries. Occasionally, a radicular cyst may also result as a result of trauma. Radicular cyst, also known as periapical cyst, can further be divided into certain variants. Most commonly, the radicular cysts occur in the periapical region of the tooth. So, the apical radicular cysts are the most common type. On other occasions, the cyst may develop on the lateral aspect of the root in relation to the accessory root canal. Such occurrences are rare. Even rare is another form of radicular cyst which is also referred to as a residual cyst. This is nothing but the radicular cyst which is retained after extraction of the associated tooth. The radicular cyst commonly occurs in the maxillary anterior region, followed by the maxillary posterior region. Within the mandible, it is common in the posterior region, followed by the anterior region. Since we have discussed already that radicular cysts occur as a sequelae of dental caries, we have to remember this important topic which we had discussed under the topic of dental caries, wherein an enamel caries will progress to the dentine followed by the pulp and reaches the periapical area. Once the odontogenic infection, that is the dental caries, reaches the periapical area, it may have various outcomes resulting on the level of inflammation. If we notice here, if the periapical inflammation is of the chronic phase, it may give rise to a periapical granuloma which can result in a periapical cyst, or it may directly result in a periapical cyst. As discussed, trauma can also give rise to a radicular cyst. How does these events result in a radicular cyst? Untreated dental caries or trauma results in pulpal necrosis. Inflammatory reaction from the pulp space will reach into the periapical area and continue as a low-grade infection or low-grade periapical inflammation. This process will result in the formation of radicular cyst. At times also, the low-grade periapical inflammation may continue into a periapical granuloma which may further give rise to the development of the radicular cyst. So, this scenario describes the etiology of the radicular cyst. But to know how the cyst actually forms, we have to understand the pathogenesis of radicular cyst. The pathogenesis of radicular cyst can be described under three phases, namely the first phase, also known as the initiation, the second phase, also known as cyst formation, and the third phase known as the cyst enlargement. This image here illustrates the tooth which has been affected with caries, giving rise to the development of a cyst in the periapical area, that is the radicular cyst. The subset images here shows the various phases which we have discussed just now. So, the first phase is also known as the phase of initiation. In this phase, dental caries or trauma will result in a periapical infection. We have already discussed that before periapical infection there will be necrosis of the pulp. We have to remember here that the periapical infection is a low-grade inflammation which will result in proliferation of cell rest of Malassez. As we have discussed already, the cell rests of Malassez are remnants of the Hertwig's epithelial root sheath which remain in a quiescent state in the periodontal ligament space following completion of root. So, a low-grade periapical inflammation will result in proliferation of these cells, such as it forms an island or mass of cells in the periapical area. The phase 2, also known as the phase of cystification, these proliferating cells will increase in size, giving rise to a larger island. As we can see here that the local capillaries in the periapical area are the source of nourishment for these cells. Whenever these proliferating cells increases in mass, the central cells are devoid of nutrition, such that it results in liquefactive necrosis of this central area of cells, resulting in a lumen within this island. This is the phase 2 of the pathogenesis of radicular cyst and is referred to as the phase of cystification. The third phase is also known as the phase of enlargement. Following cystification, there is increase in osmotic pressure. This is due to the degenerative products which results in increased protein content within the center. The resulting increased osmotic pressure will result in ingress of fluid from the surrounding connective tissue into the lumen. As this process continues, the hydrostatic pressure in the lumen increases, which forces the epithelial cells apart along with the connective tissue. This is what results in enlargement. So, the phase of initiation, phase of cystification and phase of cyst enlargement are the three essential components to describe the pathogenesis of radicular cyst. So, discussing the clinical features of radicular cyst, it should be remembered that the associated tooth is always non-vital. This is the most important point which we have to consider when giving a diagnosis of radicular cyst. Other clinical features associated with radicular cyst include the following. These cysts occur more commonly in the permanent dentition and can occur at any age. Radicular cyst in association with the deciduous tooth is rather uncommon. The maxillary anterior region is one of the most common locations for radicular cyst. This is because the maxillary anterior region is more prone to trauma. Also, the associated tooth may be deeply carious. The posterior teeth are more commonly affected with caries, and that is the reason why the second most common site for radicular cyst is the posterior region. A traumatized tooth, as you can see in this picture, will show a brownish discoloration. This is because of the vascular collapse occurring in the pulp as a result of trauma, such that the RBCs break down, giving rise to hemosiderin pigments, which gives rise to a discoloration. A traumatized tooth which has resulted in pulpal necrosis will always appear brownish like this. It is easier to identify a deeply carious tooth based on its appearance. So when the radicular cyst follows a chronic course, it may be associated with dull pain in relation to the affected tooth. The tooth may be mildly tender on percussion. However, in certain situations, when there is an acute exacerbation of the lesion, the tooth may become extremely painful and sensitive to percussion. Occasionally, in the late stages of the radicular cyst, it may result in excessive cortical expansion, resulting in swelling of the alveolus or the jaws, as seen in this image. The radiographic features of a radicular cyst are characteristic. It presents as a well-demarcated, round to oval radiolucency, a unilocular radiolucency with a sclerotic margin. It should be noted that the size of the radiolucency is usually larger than 2 cm. A periapical radiolucency which is less than 2 cm may be indicative of a periapical granuloma. So, a dimension of more than 2 cm showing a well-defined unilocular radiolucency in association with the root of a tooth is indicative of a radicular cyst. It should be noted that in that area there is loss of lamina dura surrounding the root. Occlusal radiograph may show cortical expansion as seen in late stage of the disease. It should be noted here that even though the radiolucency is related to the apex of the root, it seldom causes any tooth resorption. Root resorption is an important aspect of a neoplastic process. Radicular cyst is non-neoplastic and hence there is no resorptive changes in relation to the tooth root. Aspiration of the cystic contents may give certain clues regarding the cyst. It should be remembered here that FNAC should not be considered as a diagnostic technique in case of cysts. However, in case of clinical confusion, aspiration is performed to observe or evaluate the nature of the cystic content, following which an incisional biopsy is always recommended. So, in case of a radicular cyst, the cystic fluid upon aspiration may be watery to straw-colored fluid. It may also be a semi-solid brownish material of paste-like consistency. On some occasions, shimmering cholesterol crystals may also be encountered in the cystic fluid. The fluid in a radicular cyst is composed of breakdown products of degenerating epithelial cells and also contains the inflammatory cells and connective tissue components. The total protein content of a cystic fluid of radicular cyst is in the range of 50 to 110 grams per liter. In addition, water and electrolytes will be present, and in some cases, cholesterol crystals, which are basically breakdown products of red blood cells, will be seen in the fluid. So, how would you diagnose a radicular cyst? The answer is simple. Biopsy is always considered to be the gold standard for diagnosis of any pathology, and this holds true in case of radicular cyst as well. Before we discuss the histopathological features of radicular cyst, let us revise an important concept which we discussed in the previous lecture as well, that is the parts of a cyst. As discussed previously, a cyst will generally have three parts, that is the cystic lumen, the cystic lining, and the connective tissue capsule. We had also discussed that it is the cystic lining which actually characterizes the type of cyst. So, in case of radicular cyst, the cystic lining is composed of non-keratinized stratified squamous epithelium. At this point, I want to remind an important point which would rather be confusing at some times. Whenever we are examining a epithelium under the microscope, we should be clear that it is indeed the lining of a cyst and not a surface epithelium. So, to understand this, we have to keep in mind few important considerations. Here you can see a photomicrograph of a lesion. Here is the cystic lumen, the lining, a connective tissue capsule. But how do we know that this is in fact a cystic lumen and a cystic lining? If you can note here, the epithelium here is almost flattened and does not show any marked ratty ridges. This is a characteristic feature of a cystic lining. The epithelium connective tissue interface in a cystic lining is always flattened. However, a regular epithelium will show well-formed ratty ridges which may vary from location to location. Another point to be considered here is clinico-pathological correlation. It should be well observed that from which location the incisional biopsy is taken. If the biopsy is taken from the cyst within the cyst itself, it should definitely be showing the cystic lining. Also, the other clinical features like the radiographic features and other associated findings would point out to a provisional diagnosis of cyst. In such cases, when we observe the biopsy specimen, we would be sure that we are actually looking at a cystic lesion and not otherwise. So, to list out the histopathological features of radicular cyst, we need to remember that 2 points are extremely important. One, that is the cystic lumen is lined by non-keratinized stratified squamous epithelium, and the second is that the connective tissue capsule is composed of dense chronic inflammatory cell infiltration. These 2 points will always be seen in a radicular cyst. In addition, depending from case to case, other features may vary. Most of the cases of radicular cyst will reveal an arcading pattern within the epithelium lining. The connective tissue capsule may show some cleft-like spaces known as the cholesterol clefts. Hyaline eosinophilic bodies may be seen in the epithelium lining. These are referred to as Russian bodies. Or some eosinophilic globular bodies may be found within the connective tissue referred to as Russel bodies. Of the epithelium lining reveals that it shows numerous proliferative pattern such that it encloses the connective tissue within itself. This proliferation of the epithelium results in arc-like pattern which resemble the arc-shaped bridges of the medieval times. Hence, this pattern of the epithelial lining is referred to as the arcading pattern. And this pattern is commonly seen in radicular cyst. In addition, the connective tissue capsule may show numerous needle-like spaces or clefts, which can be easily appreciated in the low power. These cleft-like spaces are referred to as cholesterol clefts. It is common to find some brownish pigments or hemosiderin pigments around these cleft-like spaces. Some extravasate RBCs may also be seen. So basically, since there is a chronic inflammatory reaction within the connective tissue capsule, it results in extravasated RBCs. These extravasated RBCs may undergo disintegration to release hemosiderin pigments and cholesterol. These substances are accumulated in the tissue. However, during tissue processing, the cholesterol is washed off, leaving empty spaces within the tissue, which are observed as cholesterol clefts in a biopsy specimen. Other than this, the lining of the cyst at certain times may show some eosinophilic hyaline material as seen in this picture. These are referred to as Russian bodies. It is thought that these Russian bodies are hematogenous in origin and may be commonly seen in lining of the radicular cysts. Furthermore, Certain eosinophilic globular masses can be seen within the connective tissue capsule. Such masses are referred to as Russel bodies. These are large eosinophilic homogeneous immunoglobulin containing inclusions usually found in a plasma cell. The Russel bodies are caused by excessive secretion of normal secretory protein within the plasma cell. They may be seen in the radicular cysts. So, once the diagnosis of radicular cyst is confirmed, it requires a series of treatment options. The treatment of radicular cyst will therefore include root canal treatment, episectomy, and cystic enucleation, or it requires the extraction of involved tooth and curettage of the apical zone. So in the first scenario, an apical window is opened on the alveolar bone, resulting in exposure of the cyst. The cyst is then removed in total. This is known as cyst enucleation. Following cyst enucleation, the root end of the affected tooth is amputated. The procedure also known as episectomy. This is to remove any foci of infection in the apical foramen area. Following this, it is retrogradely filled and root canal treatment is done on the tooth and obturated. So once all these three procedures are combined, it will prevent in any future inflammatory reactions in relation to that tooth. The second scenario, which involves extraction of the tooth, will require thorough curettage of the apical zone to remove the cyst in total. If the curettage is not done thoroughly, it may result in the formation or the presence of a residual cyst. So to understand the histopathology of radicular cyst, it is important because these cysts are known to cause extensive jaw resorptions, expansions, which may result in pathological jaw fracture. The radicular cysts show a minor chance of neoplastic transformation. A radicular cyst, if left untreated, may result in a form of cyst known as the residual cyst. So, residual cyst is nothing but a retained radicular cyst from a tooth that has been removed. If we subject a residual cyst to a biopsy and observe the specimen under the microscope, it may show features which are similar to that of the radicular cyst. The radiograph here shows a classical example of a residual cyst. Here you can see a large unilocular radiolucency in between the canine and the molar. So, this would have been a radicular cyst in relation to a premolar. The premolar would have been painful and the patient would have reported for treatment of the same. However, the treatment would have only included extraction, leaving the cystic lesion behind. So this would be a case of negligence where the cyst has been left behind in the jaw without any active intervention to remove it. So a bridge or a FPD which has been provided later would be severely affected by the expansion of the cyst, which would affect the prognosis because it would directly affect the abutment tooth. So a preoperative radiograph should be thoroughly examined before extraction of any tooth, and any cystic lesions present in that area should be ruled out. A biopsy specimen of the residual cyst will reveal the cystic lumen, the cystic lining, which is composed of non-keratinized stratified squamous epithelium. The lining may not always reveal the classic arcading feature. The arcading pattern is more prominent when the amount of inflammatory component is more. However, since in the residual cyst there is no direct communication to the cyst from the outside, the inflammatory component will usually be less within the connective tissue capsule. So, these were the description of the radicular cyst and the residual cyst. To summarize, radicular cyst is an inflammatory cyst of odontogenic origin. Generally occurs as a sequelae of dental caries or trauma. The involved tooth is always non-vital. Presence as a unilocular radiolucency associated with the root of the tooth. Radicular cysts have a propensity for cortical expansion. These cysts arise from the epithelial cell rests of Malassez. Biopsy specimen would show a cystic lumen that is lined by non-keratinized stratified squamous epithelium and shows inflammatory cell infiltration within the connective tissue capsule. Treatment involves cystic enucleation and root canal treatment of the involved tooth. We should also remember that accurate treatment should be performed for case of radicular cyst, which involves the tooth and the cyst, so as to prevent occurrences of the residual cyst. With this, I want to conclude today's topic. I hope I have explained all the important aspects of radicular cyst. In the next lecture, we will be discussing the clinicopathological aspects of dentigerous cyst and odontogenic keratocyst in detail. We will also be able to identify, illustrate and differentiate the histopathological features of dentigerous cyst and odontogenic keratocyst. We will also recognize the significance of histopathological report of cystic lesion and suggest treatment options. Any doubts or clarifications for today's topic can be posted on the Google Classroom. A discussion page has already been created for the topics cysts of the jaws and soft tissues. You can post your doubts and comments on the link provided on the e-portal. So we are now in the 7th week of the lockdown. I request one and all to follow all the precautions to keep yourself and your family members safe. Stay at home, stay safe. Thank you.